Welcome, everyone. This lecture is going to cover jaundice. We have a couple different types. We're going to go over terminology, assessment, interventions, and some education. Let's get started. First and foremost, let's go over the terminology. We've got to get that straight before we start on anything else. Jaundice is defined as elevated bilirubin levels resulting in the yellowing of the sclera, skin, and mucous membranes.
Bilirubin is defined as the waste product produced during the breakdown of red blood cells. There are two types of bilirubin, unconjugated or indirect, and conjugated or direct. For unconjugated bilirubin, this is the heme that's released from hemoglobin during the whole process of red blood cell breakdown, and it's converted directly to unconjugated bilirubin. The unconjugated bilirubin is then transported to the liver. So this is fresh off the press heme that has just been broken down from the red blood cell breakdown process. Nothing else has happened to it yet, and that's why we call it unconjugated. That unconjugated bilirubin then gets transported to the liver, where it is converted to conjugated bilirubin. There's a complex physiological process that we don't need to get into for the NCLEX, but it has to happen because that's how bilirubin is excreted. It's excreted in the stool, and you can't just excrete the unconjugated bilirubin. That heme gets broken down, and then we have to transport it to the liver, go through a process for it to be converted to conjugated bilirubin, and then it can be excreted in the stool. So a bit complicated, but it's important to know that there's two types of this bilirubin because that affects we measure them differently and they affect jaundice differently. Essentially, when your provider orders a bilirubin test, you're going to see unconjugated levels and conjugated levels. Again, unconjugated is also known as indirect, and conjugated is known as direct. So I just alluded to those lab values. Let's go ahead and jump into the normal ranges of bilirubin. Okay, so again, we have our conjugated, our unconjugated, and lastly, our total bilirubin, which is simply going to be our conjugated and unconjugated values added together. So all the total of bilirubin. Now, what a normal lab value is highly dependent on the age of the infant, and I cannot stress that enough. It's so highly dependent that it's actually going to come down to specifically how many hours old the infant is. There's a different lab value range for a 1 hour old infant versus 2 hours, 12 hours, 24 hours. Your healthcare provider is going to use something called BiliTool to plot the age of the infant and hours of life against their level of bilirubin. And that is what will tell them if it is a safe or unsafe level. So these lab values are kind of difficult to give you a range of normal, abnormal, what's dangerous, and what needs treatment. You're not going to have to determine that as a nurse, so we're not going to get too much into it. You're not going to have an NCLEX question that asks you about the range of bilirubin because it is so complicated to interpret. You do need to know that it's dependent on the age of the infant, and I'll give you these ranges as a general idea of what to expect just to help steer you towards thinking if this is an infant that's normal or potentially experiencing jaundice. So for total bilirubin, zero point 0.8 to 12, unconjugated bilirubin, zero point 0.2 to zero point 0.7, and conjugated bilirubin, zero point 0.1 to zero point 0.4. I don't want you to spend too much time memorizing those lab values because, as I mentioned, they really are dependent on the age of the infant, specifically in hours of life. So just know your healthcare provider will interpret these lab values with BiliTool by plotting the level of bilirubin compared to how many hours of life the child is. Okay, I think that's everything I need to mention about lab values. I want to touch on one other topic before moving forward, and that's why we so often see jaundice in newborns. I think this really matters for understanding the overall physiology that we're talking about with jaundice. The bottom line is that in infants, their livers are immature. They're not fully functioning left yet. Remember back in our fetal circulation lecture, then in fetal circulation, we had something called the ductus venosus, and its job was to bypass the fetal liver so that there was no blood circulating through it. The liver wasn't functioning in utero, it wasn't doing its job. So, naturally, if our liver was being bypassed in fetal circulation, it was getting no blood flow, it was not functioning and doing its job, it follows that at 1 hour of life, that liver isn't going to be doing a whole lot. It's still very, very immature. It has a long way to go to be fully functioning like it is in you and I. So, in utero, the placenta is doing everything. It's removing bile from circulation because again, that fetal liver is being bypassed by the ductus venosus. It's going to take a little bit for that liver to kick in and start removing bilirubin, specifically converting unconjugated bilirubin to conjugated bilirubin, because that conjugated bilirubin can be excreted in the stool of the newborn. That unconjugated bilirubin will just circulate and start to cause jaundice, if not converted by the liver and then excreted in the stool. So, because we have an immature liver in the newborn, we tend to see jaundice in this population. We can also have jaundice in other populations. It is almost always going to be related to liver trouble, though. Liver failure. Alcoholics who go through severe cirrhosis and end up in liver failure, those are the people you're going to see jaundice in, and it's because their livers aren't working. They're not converting unconjugated bilirubin to conjugated bilirubin so we can excrete it in our stool. Okay, that's the basic physiology and terminology. Let's move on to the two different types of jaundice that you will see in infants. We have pathological jaundice and we have physiological jaundice. Okay, I'll start with pathological jaundice. This is going to be jaundice that occurs within the first 24 hours of life. The serum bilirubin will be compared to what the normal value is based on the hours of life. Remember, that's that Billy tool that your providers are going to use to determine normal. Anytime jaundice appears in that first 24 hours, though, it indicates there's some other type of problem or disease process going on that needs to be addressed. It is not normal for jaundice to appear in the first 24 hours of life. It usually takes at least a day for the amount of unconjugated bilirubin that is needed to manifest jaundice to build up. It's if it shows up in the first 24 hours, something else was already going on so that that level of unconjugated bilirubin was already present because it simply takes longer than 24 hours for that level of unconjugated bilirubin to build up to a high enough point to show jaundice in our clinical assessment. Some of the things that could be going on that can cause pathological jaundice are innate issues with the liver. Maybe the infant had liver problems in utero, some congenital anomaly that causes problems with the liver. And in that case, they would already have elevated bilirubin going into their life. So we might see pathological jaundice in the first 24 hours. Another really big one is an ABO incompatibility. Now, we have a whole nother lecture that gets into ABO incompatibilities, but remember, this is when mom and baby have different blood types, and it causes problems for baby because they have cells that are incompatible, and that means a lot of breakdown of red blood cells. And remember, unconjugated bilirubin comes from the heme being broken down during red blood cell breakdown. So if we have an ABO incompatibility, we therefore have a lot of red blood cell breakdown. We therefore have a lot of unconjugated bilirubin, and we're going to get sky high levels of it, which will present and show jaundice clinically in the first 24 hours of life. Always pathologic if it shows up that early. Physiologic jaundice is going to take longer. That is actually a normal process, and we'll get into that now. Any jaundice that shows up on day 2 of life, 3 of life, later on, just not the first 24 hours, is normal. This is expected process. It comes from an immature liver and it is not considered pathologic unless something else comes up and presents an issue. It's just due to the normal transition from the placenta doing all the removing of the bilirubin to the liver now doing the whole job of removing the bilirubin. After the fetus was born, fetal circulation started to transition, that ductus venosus closed, and the fetal liver started working. Well, now it's the fetus's job to remove bilirubin. The placenta is no longer there doing the work, so the liver of the new baby has to do it. It takes a little bit for this, though. That liver is immature. It's been bypassed for 9 months. It has not worked yet, so it's just not efficient in removing, not necessarily removing, converting that unconjugated bilirubin to conjugated bilirubin for excretion. It's not efficient yet. So some unconjugated bilirubin starts to build up, and that leads to the clinical presentation of jaundice. So, when it appears on day 2 or 3 of life, we know it's normal. There is likely no pathologic process going on. We're simply seeing the byproduct of the normal transition of the fetus's, now baby's, liver start to function and conjugate that bilirubin. This really doesn't need inpatient treatment usually, but that depends on the levels. 9 times out of 10, it's simply going to be followed up with the child's pediatrician. They may trend those lab levels or just look at the clinical assessment of the infant and ensure that they are trending in the right direction, that their liver is starting to function and clear that bilirubin, that it's starting to pick up, conjugate the unconjugated bilirubin so it can be naturally excreted. If not, they then might look at treatment, but it's usually not an issue. When it is an issue, it leads to something called kernicterus. That is the biggest and scariest complication of jaundice and why we follow along the lab values and the clinical assessment so closely. So I want to make sure we dedicate some time to what kernicterus is and why it's so dangerous. Kernicterus is a type of brain damage that can result from very high levels of bilirubin in the blood. Specific long term complications include cerebral palsy, hearing loss, problems with vision, problems with teeth, intellectual disabilities, learning disabilities, things of that nature. All of these disabilities are coming from complications with the central nervous system, the CNS. Very high levels of bilirubin cause problems in the nervous system, and that's why we see things like cerebral palsy, intellectual disabilities, vision problems, hearing problems. We've essentially clogged up the brain, clogged up the nervous system with this unconjugated bilirubin. That's what causes kernicterus, and that's why people get so worried about jaundice because they know that these are long term complications. It is completely preventable. If we monitor for the signs and symptoms of jaundice, we test our levels of bilirubin in the hospital. We follow up with pediatricians and treat promptly. No infant should ever suffer from kernicterus and the long term complications. Um, every aspect of jaundice is either physiologic, a normal process of the fetus transitioning to outside life. And if it is pathologic, if there is an ABO incompatibility, or an innate problem with the infant's liver, it can always be treated. We have ways to decrease the levels of bilirubin in the infant's system. So kernicterus is really unacceptable. We should not ever be seeing this as healthcare providers and as nurses. We should be preventing it. I've talked a lot about the clinical assessment of what an infant looks like that has jaundice. Let's go a little bit more into that and look at some photos to just tune up your assessment skills. The major things you're going to be assessing to decide if you think an infant is jaundiced or not are their integumentary system. You're going to look at their skin, their eyes, their mucous membranes, and in general, you're looking for yellow. Does their skin have a yellow or orangish hue to it? Their eyes, their sclera around their pupils, the whites of their eyes, are a really good place to look because on infants of every single ethnicity, your sclera should be white, and that will be one of the first places that you really pick up on seeing the yellow tinge. So observe there very carefully. Another good place to look, especially on darker skinned babies, are the oral mucous membranes. You see, this is an older patient here that maybe has some liver damage or something. With his mouth open, you can see in the back of his mouth all those mucous membranes are very yellowed. On babies, you can look at their gums, their nail beds, any of those areas. Look for a yellow tinge, a yellow hue. When those levels of bilirubin start to elevate beyond a normal level, this is how they manifest. They manifest in a yellow hue. So when someone says, "Oh, my baby is jaundiced," or "Oh, that baby looks jaundiced," this is what they mean, this yellow tinge. And it's all due to those high levels of unconjugated bilirubin. So, if this happens so often, and if it's a normal part of the physiology of transitioning to newborn life, what do we do about it? Time to talk about treatment. Treatment for jaundice is quite simple. It is called phototherapy. I have a couple pictures here. That first one up on top is called a billy blanket. It is a way of delivering phototherapy to an infant where they can still be bundled, swaddled, and held. And then down below, you see a little baby in an incubator who is getting phototherapy from a spotlight or a neo blue light shining on them. Sometimes I say to parents that they're in the tanning bed just as a joke, but that's kind of what it looks like. These blue lights, this phototherapy, simply helps break down the bilirubin so it can be excreted in the feces. So remember, we had our unconjugated bilirubin get transported to the liver. The liver conjugated it. We then had conjugated bilirubin that was excreted in the feces. The phototherapy does that middle step for the liver so that we can get rid of that bilirubin. So in a neonate that has an immature liver or an ABO incompatibility and they have too much unconjugated bilirubin, this phototherapy conjugates it and then they can poop it out. Um, Two things we do need to ensure though, we have to make sure the eyes and genitals are covered. That light can be damaging to the eyes and the genital region. So ensure that the infant has a diaper on and that they have these cute little glasses, those little billy masks on to protect their eyesight. Um, we will monitor the level of the light. There's a little bilirubin or a billy light meter that your unit will have so that you can measure how strong the light is and keep the light at an appropriate distance if you're using an overhead light. So those are all some safety checks, some good nursing interventions to ensure your baby is safe. The phototherapy is ordered at different levels depending on how severe it is and how much unconjugated bilirubin there is to be broken down. It can be double, triple, or quadruple therapy. If they need triple or quadruple therapy, you can't just use the billy blanket. You may need the billy blanket and also an overhead light or just an overhead light. That will depend on your unit, your policies and procedures, but in general, that is what phototherapy looks like and what it does. It simply takes that unconjugated bilirubin, turns it into conjugated bilirubin so that the baby can poop it out, which is what their liver should be doing, and it's either just not ready to do it yet, it's immature, or there's a pathologic problem going on. Okay, I think that covers anything and everything that NCLEX could ask you about jaundice, bilirubin, and phototherapy. So let's dive into an NCLEX question and wrap this lecture up. Which of the following statements is true regarding jaundice in newborns? Jaundice within the first 24 hours of life is physiologic. Unconjugated bilirubin has been converted to conjugated bilirubin in the liver and is ready to be excreted in the stool. Assessing a newborn for jaundice involves inspection of the skin, sclera, and mucous membranes. Treating a jaundiced infant with phototherapy, important nursing considerations are to ensure that their eyes and